There we go. Okay, we're recording the meeting, and technical problems notwithstanding, this recording will be available to view in due course. But just before we start, I'd like to put in a plug for next week's online event, the book launch for Olga Petrovskaya's excellent work, Nursing Theory, Postmodernism, Post-Structuralism and Foucault. That event will run on the 23rd of May, kick off at 5:30 UK time, so not quite as per today. And if anyone wants to attend, but they haven't got a link yet, drop me a line and I'll make sure you get the invite or log on link. Okay, right, hello, my name is Martin Lipscomb and I'd like to welcome you to today's event. Pain cannot just be whatever the person says, a critique of a dogma. Now, as I'm sure everyone recognises, the title of this event apes Margot McCaffrey's famous assertion that pain is whatever the experiencing person says it is, existing whenever, wherever he or she says it does. And this assertion, this belief, will be challenged today by Charles Djordjevic, who will outline the argument presented in his 2023 nursing philosophy paper of the same name. That's the same name as today's event. Now, Charles's arguments are, in my view, persuasive, but then I would say that because at almost the same time that Charles was writing his paper, I addressed similar themes in a book chapter that appeared in the edited work Complexity and Values in Nurse Education, Dialogues on Professional Education. We didn't know of each other's interests when formulating our positions, but overlaps like this happen probably quite frequently. Now, if Charles's argument is accepted, and as I say, it is persuasive, interesting and troubling questions must be addressed by nurses in practice and education. Within clinical environments, shorn of the certainty that accompanies McCaffrey's dictum, nurse responses to patient reports of pain are complicated, quite significantly complicated. Alternatively, in education, insofar as students need clear and unambiguous instruction, papers such as Charles's, papers that question or undermine taken for granted assumptions and ways of working, generate considerable problems for educators and students alike. Charles's synopsis of his work, which he'll set out in a minute, therefore lays the foundation, sets the scene for a broader discussion or explanation of how possibly claims of the sort presented in journals such as Nursing Philosophy are, well, assuming they are, to be integrated into the curriculum, into patient care, into education. And to this end, Barbara Pesut, Mark Risjord, Abby Martin, and Mar'yana Fisher respond to some of the difficulties and anomalies thrown out by this sort of work. They also tentatively offer ways to assimilate such thought into nursing practice. Right, I'll introduce speakers just before they speak, and after speakers have spoken, we'll take questions in the usual way. So, without further ado, firstly, Senior Research Fellow Dr. Charles Djordjevic of St. Olaf College, Minnesota, talks to his paper, Pain Cannot Just Be Whatever the Person Says, a Critique of a Dogma. Now, Charles, I'll just pop your PowerPoint onto the screen using my button pressing abilities. Good. And it should pop up any second. I'll turn off my microphone. If everyone who's not speaking could turn off their microphones, and the floor is yours.
Thank you very much. And I'd just like to thank you and the organizers for putting this together, my co-presenters for engaging with this paper. To be honest with you, I'm always rather shocked that people find what I'm up to interesting. It's very much sort of a work of self-clarification, and so I'm happy people found something to it, and I'm looking forward to an incredible discussion. So with that said, let's get into it. So the paper has two fundamental claims, right? The first claim is that McCaffrey's famed definition of pain is whatever the experiencing person says it is, generates intractable problems, and ends up ultimately being incoherent. Second, it tries to understand pain, the term, much more intersubjectively, not only about these brute occurrent private sensations, we'll get into that a little more later, but also about sort of breakdowns in what I'm calling human forms of life. Again, we'll get into that later. And with that said, let's see how I'm going to get there. So the paper structure and the structure of this talk is as follows. First, I'm going to give you a rational reconstruction of what I take to be McCaffrey's position. So after that, I'm going to argue that this position immediately faces three deep challenges, pardon me. Third, I'm going to argue that even deeper than those is going to be just an incoherence that underlies this very picture. And finally, borrowing a bit from good old Ludwig Wittgenstein, the mad Austrian man, I'm going to argue that the only way out of this is we need to just break with a picture of language, a way of thinking about what pain talk actually is doing for us. We'll get there in a minute. Okay, so let's reconstruct McCaffrey's position. I should note at the outset that any rational reconstruction, which is what I take to be offering in this paper and in this little bit of a talk, is going to have some element of post hoc rationalizations, right? McCaffrey's remarks are scattered, over 40 years through various and sundry texts, everything from textbooks to little pop articles. And so this is me putting her position together. As far as I'm aware, she never fully articulated it in a systematic manner. So caveat emptor, right? If you read these texts, you may well be able to put them together in a very different way. In any case, the way I want to reconstruct her position is on three interrelated levels. So there's the metaphysical, there's the epistemic or perceptual, and then there's the semantic or the meaning level. So metaphysically, I think that ontologically, McCaffrey and some of her collaborators suggest that pain depends on specific neurophysiological processes that generate it. I think she reads that very strongly, right? I think she thinks that these processes are necessary to and sufficient for the conditions. The sufficiency for me is really important. I think that she thinks this because effectively she tells you things like unconscious patients can still have pain, sleeping patients can still have pain, etc. What suggests she's completely pulled apart whatever pain is and our experience of it, right? So someone can have pain even if they're not experiencing it. So that's where that comes from. From there, I think she moves to an epistemic step. So this is where her famed definition begins to come into play. She's going to think about our experience of pain as a perception of pain, right? So you have this, if you like, inner object somewhere, and then you experience in it, and that's your epistemic access to it. That's the way you understand it. She thinks this is the best we have at the moment. She thinks the science of pain is in its infancy, and because of this, this needs to be set as the gold standard. She actually sort of waffles here. Some of her texts suggest we're never going to get much further. Others suggest we might get further when, the future neuroscience comes and the end of history and all this business. I'm not sure how she settles that. The last is that given these two moves, a very natural idea of what pain talk is comes into play, which is that it's propositional. That's just a fancy Dan philosophical word for pain talk is a way of describing or representing pain. There's more to it than that. We can have an endless amount of debates about what a proposition really is. God knows we've been playing around with that for 60 years now, so we can do that in Q&A. But for this talk, all it means is that pain, when I say something like I have a pain, there are truth conditions. There are conditions under which that's true or false, and understanding it requires grasping those. Okay, so what are the problems that this immediately throws up for us? I think there are three. One of them has to do with management. So this way of thinking suggests that treatment of pain is just correcting the underlying neurophysiological process, right? So pain, that term is going to be univocal. It's always going to refer in the same way to the same basic thing, be that my perception of the pain or the underlying pathophysiology. And everything else is going to be biased. It's going to divide out, right? If I have a sore throat and I go to the doctor and they do a strep test, any other considerations apart from what bacteria the strep test turns up, strep probably, are irrelevant, right? They're biased, they're interfering with the actual assessment. I think that this view ironically invites very inhuman reactions to pain, right? So let me give you a concrete example of what I mean, right? Imagine that I spill coffee on myself because I'm clumsy, which is very true. And I go to the hospital, and then imagine that someone I'm seeing romantically throws coffee on me, and I go to the hospital with a burn. We can imagine the burn is the same. We can imagine that we've gotten to the point where we can map out the neural circuitry, and that's the same. Nevertheless, I want to say that it's absolutely inhuman to try to respond to both of these cases with the same treatment modality. You know, in one case, doctor will give me a pill or a couple pills, tell me how to care for the wound, say not to be clumsy, send me on my way. In the other case, we want the provider to engage with a very nuanced conversation about the status of the relationship, about possible social support if I choose to leave it, things like this. That's vital. And I think McCaffrey is going to have to end up condemning that as bias, right? The neurophysiology is the same, the burn's the same, the treatment should be the same. So that's one worry that I think cuts deeply for her because she is deeply ethically motivated, and rightly so. Worry number two, the meaning of this, right? So McCaffrey says that only a patient can define her pain, right? That's what I take her walk away from that famous definition to be, right? Only she can access it, only she knows what it is, only she can define it. However, she also wants to tell us that medical staff, be these nurses, doctors, pharmacists, physical therapists, whomever, can educate the patient concerning, you know, the use of a pain scale, reporting pain, and so on. This just strikes me as pretty obviously inconsistent, right? If I get to define what pain is based solely on my subjective fiat, I don't know what education is, right? So a good way into this is think about if I cross out pain and use a nonsense word like, you know, boop boopity doo. You're not going to be able to tell me my boop boopity doo can't be blue and the square root of -1 and tasty, right? You don't have the ground to make that. On the other hand, if I can be educated, if you can tell me, look, your pain can't be the square root of -1, then it's not just my fiat anymore. So she needs to resolve this inconsistency. And again, I don't think she can. Third problem here is going to be this way she wants to think about perception, right? So remember, she's trying to think about perception as like, I have this pain, and then the experience is sort of me perceiving it, and I have privileged access, blah, blah, blah. Problem is, on the one hand, she wants to cash this out in very neurophysiological and causal terms, right? A perception is just a process, right? It's how I perceive, right? We can tell a very complicated story about neural activity and such. On the other, she really wants pain to have content, right? She really wants there to be something I am perceiving. The problem is that this doesn't hang together, right? I can give you a beautiful story about the physics of acoustics, about, you know, how sound waves impacting my eardrums set off neurons. You're never going to be able to derive, you know, showing a bias on my part. You're never going to be able to derive the youthful exuberance of a Katy Perry song from that, right? There's no Katy Perry song in the pitter patter of neurons, right? So we have a disconnection. Deeper problem for her, I think, is going to be that I think this ultimately just falls apart. Here's why. So it seems like this term pain for her can refer to one of two things, right? It can refer to my subjective experience, or it can refer to this underlying neurophysiology. If pain refers to this subjective experience, then the underlying neurophysiology seems like it's irrelevant, right? The person can't access that. I can't think about what my neurons are doing. I don't know what it would mean to introspect that. And so it seems like these just come apart completely. On the other hand, there's also a problem there that I think you end up losing complete track of how the term actually means. On the other hand, if pain refers to this neurophysiology, then my feeling of it, my experience of it is a secondary worry at the very best for pain. It's a superficial property, to steal from Putnam. If that's so, then these pain reports are actually pretty useless for the science of pain, right? They don't get to the core, the underlying essence, right? You know, this is Putnam's famous move against someone like Thomas Kuhn. I don't care how alchemists thought about water. They weren't getting to the core of it. Same here. So either way, these can't work in the way McCaffrey wants. So what's our out? How are we going to change gears? How are we going to break with this picture? So I think one thing McCaffrey rightly wants is to insist that pain is about something, right? And that's admittedly me reading into her, right? I think that's the part of the point of her subjective definition. She wants this not to just be screaming into the void, right? I think that McCaffrey's mistake, or one of them, is that she wants pain to be about some specific, discrete, disconnected, ontologically independent feature of the world. Like pain works like pin talk or mountain talk or whatever. There's something out there, and my words are pegging it, and it's discrete, it's given, blah, blah, blah. I think this is a mistake, right? To borrow a phrase, pain is more than a feeling, right? It's a pattern that emerges in the course of human life and the way we engage with the world. That sounds, again, very highfalutin and philosophy-ish and all this. The best way to bring it out is with this fun examples from misattribution from psychology, right? So one of the famous studies is they had men walk across a bridge that was, looked dangerous. And in half of the group, they had the attractive Confederate who would give them a meaningless survey and give them her phone number. An unbelievably high percentage of those men called this woman, and the prompts they were given had pretty overt sexual themes. And the way the psychologists understood this was they took the physiological changes, this elevation in heart rate, as a sign of lust, not of fear of this bridge, which is fascinating. I think the same is going on with pain. I understand my sensations or my experiences only through and against the background of the context and the way the world is, right? That's how I make sense of myself. An entailment of this is that to know what pain, that term actually means for patients, is to have some sense of what these patterns are. And this, and I praise Dame Saunders in the paper because I think she saw this incredibly clearly. This can take you months or years to fully and completely articulate, right? Which does lead to substantial questions about how we actually manage pain in, say, an acute care setting like a hospital. But I think that that's part of where you're going to end up. So that's my paper briefly. I again thank everyone for taking the time to engage with it and me. I'm truly humbled by it. That's my email. All of the references are in the paper, so please feel free to look at it if you're confused about why I'm putting things together the way I am. Thank you very much.
Thank you, Charles. That was, as I knew it would be, very interesting. Okay, the first person who responds to Charles is Professor Barbara Pesut, Principal Research Chair in Palliative and End-of-Life Care at the University of British Columbia, Okanagan. I'm sure I've just mispronounced that dreadfully. Barbara provided a response commentary to the chapter that I wrote in the book Complexity and Values, and in that response she said why she thought I was mistaken. So very interested to see what you have to say here, Barbara, and over to you.
Good, thank you. Well, I'm delighted to be here today, and that was just an excellent explanation of the article. I'm always amazed at how much more I grasp when somebody actually talks to me about it. But I'm going to begin with a story because it really illustrates to me how these memes become powerful signifiers, and maybe not always in a good way. So I was practicing as a post-anesthetic care nurse when Margot McCaffrey was actually most famous. In the early 90s, she was a traveling speaker promoting her definition and highlighting what she considered to be misperceptions about pain, which ironically, many of them fueled the promotion of oxycodone by Purdue during the same period. She came to our hospital, and I remember being deeply inspired by her message. It was like a quasi-religious experience. I returned to work deeply committed to pain is whatever the patient says it is. So for those of you that don't know PACU nursing, as nurses, we have unlimited opioid to administer. So I had a patient who kept telling me she was in pain after a great deal of morphine, and so I kept giving her more. Well, it wasn't long before she was in respiratory compromise. It was at this point that I realized my quasi-religious experience was completely unworkable from a clinical decision-making perspective. I traded my hard-won clinical expertise for a meme. I agree with so many of Charles' points, and I would view what I have to say as perhaps adding to those points rather than detracting from them. I do agree that an intersubjective account of pain is required, although I would argue that there are also times when you do just need to give the opioid without any need to understand what's going on. If I'm post-surgical, just give me the, please don't fuss about how I'm perceiving the pain or what it means to me. But for more complicated scenarios, intersubjectivity perhaps doesn't quite capture enough of what is required. It certainly captures my responsibility to treat you as a human, to accept without judgment your expression of pain, and to understand as fully as possible your experience of that pain. But I would argue that radical subjectivity is only one piece of the picture because we've downplayed the expertise that nurses have. My professional responsibility is to discern and weigh as many of the factors as I can, including the social factors that may be influencing that subjective account. For example, I think we're living in a unique social time in which the total pain experience goes so far beyond our understandings of pain 20 years ago, and Charles referred to this. McCaffrey's misperception that the use of opioids does not result in psychological addiction has been cruelly debunked and an enormous cost to many. Our almost cult-like fascination with happiness continues to render those experiencing suffering as invisible. And watching the planet that sustains us groan and change has had a profound impact on our collective well-being. And these are just three of the social experiences that we live with daily that are really difficult to give expression to. I'm not sure we even have really concepts to embrace the social factors of grief and loss that tend to tear away at us daily. And if you think back to Cicely Dom Saunders' expressions of total pain, it would actually really embrace all of this. The point is, as professionals, we can acknowledge the sociocultural context in our intersubjective engagement with pain, but perhaps we don't have the luxury of playing in those ideas. At the end of the day, we are professionals with scientific knowledge who are the gatekeepers to powerful drugs that have been weaponized, corporatized, and incentivized. We cannot afford the fluffy approach of pain is whatever the patient says it is. Such an approach is a cop-out that is characteristic, I believe, of the many ways in which nurses are positioned as the advocates of all things caring and person-centered, rather than critically thinking professionals who have an obligation to sort out pain that is amenable to nursing intervention from pain that perhaps needs to be sorted elsewhere. I would argue that nurses with vast experience with pain in different persons and contexts have legitimate authority in the pain narrative. I would further suggest that the nursing meme is, yes, I believe you are in pain, but let's sort out together what is best practices in treating that pain. In this way, the nurse believes the account, but holds on to the professional responsibility for best practices in treatment, even if that doesn't agree with what patients believe they need. I want to just take a last minute to sketch out how a parallel debate is unfolding in Canada in the area of suffering in the context of medical assistance in dying, or MAID as we call it. Applicants to MAID are required to be experiencing suffering that is intolerable to them and which cannot be relieved in a way that's acceptable to them. Suffering, like pain, is an intensely personal experience. And so you can appreciate that those nurse practitioners and physicians who conduct MAID assessments have had to grapple with the question of how do I know that this person is suffering intolerably? And these are high stakes questions because the ultimate result is that person's death at the hands of that healthcare provider. So understanding how these assessors go about this task may be instructive of how we think about the problem of pain. First, these assessors require a credible narrative account. There must be some evidence that given the overall circumstances and trajectory of those circumstances, one might expect the presence of significant suffering. And part of that credible account is demonstrating that applicants have done their part in attempting to relieve that suffering. I think we could apply similar principles to our understandings of pain. A credible narrative account of the pain trajectory, along with taking personal responsibility for doing the many lifestyle and behavioral things that can be done to alleviate that, are important considerations in that intersubjective encounter. Second, what's fascinating is to see how the clinical judgment is often anchored more within the fundamental assumption of what it means to have control over one's life. Some MAID assessors suspend all judgment over what that person is suffering. It really doesn't matter to them because ultimately they believe the person has the right over the timing and the means of their death. Contrast, others believe that they have a responsibility to verify the suffering. They are in fact gatekeepers to the assisted death. What's important is that you can see the same thing operating in our need to define pain. Do we believe that persons have the ultimate say in their pain experience and our professional obligations flow from that claim? Or do we believe that those claims can and must be tempered by the host of factors we perceive and weigh in the clinical context? And here is where I see Charles' point of intersubjectivity most powerful. In that intersubjective process, we learn of the experience. But our subjectivity is not one of person to person, but one of person to professional. And in that, we recognize that we hold within our grasp treatments that can be as harmful as they are helpful. Thank you, and I look forward to the conversation.
Thank you, Barbara. As ever, really interesting. Okay, Mark Risjord is our second responder. Mark is Professor of Philosophy at Emory University, and as ever, Mark, I suspect you have something interesting to add here. Over to you.
Thank you, Martin. It's really a pleasure to be speaking in this context. This is a really interesting paper and a fascinating set of issues. I think Charles has identified in McCaffrey's writing a real tension in our conceptualization of pain between the kind of the objectivity of scientific conceptions of pain as a neurological state or physical state of some kind, and McCaffrey's reliance on the patient's perception, some kind of a subjective aspect of this. And he wants to argue that these leads to incoherences and that we need to reconceptualize the semantics of pain. I want to argue that the incoherences that he identifies arise from conflating questions about meaning with questions about knowledge. That is, questions about the semantics or conceptual content of pain or part of pain. It's a word with many meanings and a complicated set of uses. So conflate that with the questions of how we know that the patient might be in pain, or how the patient knows they're in pain. So this is going to be aimed at perhaps McCaffrey and perhaps at Charles as well. I'm going to take really the only thing from McCaffrey is what Barbara called the meme, right? Pain is whatever the experienced person says it is. I think there's three possible ways of reading this. There's a semantic way of reading it where you treat it as a definition of what pain means. There's an epistemic way of reading it where you treat it as a way of knowing how the patient, it's a question of how the patient knows they're in pain, how the provider knows they're in pain. And then, and as Charles said in his remarks, he sees in McCaffrey a connection between those two. I think, we have to be clear about what the differences there are. And then finally, there's a clinical set of questions about how the provider ought to respond to the patient in pain. And I think that's a reading of this statement as well. Barb suggested some of that in her remarks. Now, in his paper, Charles argues that start with the semantics, treating McCaffrey's dictum as a statement about what the word pain means, or one of its meanings, is inconsistent with the way she treats the science of pain or apparent acceptance of the science of pain. I'm going to lean into the neuroscience here, and I want to argue that neuroscience and biology more broadly, human physiology, has over the last 100 years changed the conceptual content of pain. So now it's part of the meaning of pain in the way it wasn't, say, 200 years ago. It's part of the meaning of pain that if a person's in pain, then their brain and body are in a certain kind of physical state or one of a class of physical states. I'm taking that as a part of the meaning of pain. It's very similar to the way the meaning of the word hot has changed over the last several centuries. Now, it's part of the meaning of the word hot, I would say, that if something's hot, then its molecules have a mean kinetic energy higher than the surrounding environment, maybe even higher than my own hand. Right? That's what science has done, and this is just a very common thing that we learn things about the world. That changes the way we think about it and talk about it. It changes the conceptual content. Just as a quick aside, I'm not taking the word pain to refer to anything here. I'm making a point about its meaning. I think Charles is right. If you think about pain as referring, getting its meaning from a kind of reference, you've got all kinds of problems. So I agree with him in that critique, but I want to say that pain has a kind of physical meaning to it, or part of its meaning. Now, a caveat: taking the neuroscience seriously when we're thinking about the meaning of pain is not reductionist in the sense of oversimplifying a complex phenomenon. I really want to push this point, precisely because of what the neuroscience tells us. Pain is not a simple phenomenon by any means. It involves cognitive and emotional processing. It both affects and is affected by physiological systems outside of the neural system. So it's a complicated phenomenon that involves the whole body and the relation of the body to the environment, like most perceptual kinds of things do. So it's not reductionist in the sense of we're identifying pain with some set of neurons firing. That just is inconsistent with the neuroscience. Crucially, in thinking in conceptual terms, this neurological stance motivates the distinction, which McCaffrey recognizes and Charles talks about, between the awareness of being in pain and the fact that one is in pain. A person can be in pain without feeling that they're in pain, and they can authentically report that they're in pain without being, in fact, in the appropriate range of physiological states. Now, if you want to hang on to that feeling as essential, as necessary and sufficient for the meaning, then I think you're just inconsistent with what neuroscience is telling us, and what I think is becoming a crucial part of what pain means, both in science and in clinical life and in ordinary life. This distinction, this semantic distinction I just pointed to, is crucial for understanding the epistemology. So this is a question about how I know that I'm in pain, how someone else might know that I'm in pain. And the central point is that the patient, the person who is experiencing the pain, who's in pain, is in an excellent position to know that they're in pain, but precisely because we can distinguish between the awareness of pain and the fact of being in pain, this is not infallible and it's not authority, right? A person can be in pain without, can feel they're in pain without being, and vice versa. The fact that they have the feeling is neither necessary nor sufficient as for being in pain. So epistemically, the two come apart. The patient is generally, but not infallibly, right when they say that they're in pain. That is, their epistemic position is privileged in the sense that they're in a really good position to know, but that doesn't mean that they're always right about it. The incoherence that people sense here, I think, arises when we move too quickly from the patient is in a privileged position to know that they're in pain, to only the patient can know that they're in pain. The latter is just false. Right? It's absurd to say that I can't know that someone I'm intimate with, like my wife or my kids. It's absurd to say that I can't know that they're in pain. Of course I can know that they're in pain, and to flip it around, I may know it when they don't. Right? And again, this is exactly motivated by the neurological and broadly physiological findings. So I think as an expression of epistemology, I would take the meme, the McCaffrey's dictum, as an understanding of the patient's privilege, but not their infallibility, right? So insofar as McCaffrey was meaning that, I would agree that that's a mistake. Now, this has got clinical consequences, and I think Charles is worried about a couple of the kind of consequences that would follow from my leaning into the neuroscience as part of the conceptual content of pain. Two, it eliminates clinical expertise, a point that Barbara made nicely some years ago as well. And second, that letting the science influence the concept of pain in this way leads to narrow pharmacological treatments. As he says, rating pain with scales and drugging people. And surely that's a bad thing. I don't think either of these really arise. That is, so clinical experience is necessary precisely because the patient's not infallible, right? And if we want to find clinically relevant signs of pain and ways of identifying pain, then Neuroscience is exactly what's giving us those kinds of things, and not just neuroscience, but physiology more generally, because pain involves all kinds of systems. So it's entirely possible, just in ordinary ways, clinicians have knowledge of the patient's pain that's independent and crucial, as I think as Barbara was pointing out. And as our understanding of these systems develop, we might well have indicators that can tell a patient's in pain that's independent of their statements. Finally, the idea that leaning into the physiological, neurophysiological senses of the term will lead to rating pain with scales and drugging people, that assumes that the science is narrowly reductionist. And if you think about the science, it's actually not. The science itself tells us that non-pharmacological treatments work, and they work precisely because they influence the more complicated neural processing. Pain processing goes through the cognitive and emotional parts of the brain. Interacting with those interventions and cognitive and emotional interactions will reduce pain. Why? Because they change the body, right? They change the way the body's responding. So the science itself tells us there's a wider range of interventions here than just drugging people. So as a clinical reading, I would take McCaffrey's dictum to say we have, like as Barbara was saying at the end of her talk, we have to take the patient seriously, but expressions of pain, and I want to just ring the bell that Barbara just rang about suffering. Expressions of pain are more than just statements about what I'm feeling, and I think Charles has got this right, but they're not just expressions of pain, they're expressions of suffering, and we should aim at mitigating suffering. And so we take the patient seriously when they say they're in pain. That doesn't just mean I'm in a physical state, it also means I'm suffering and we need to address the suffering. With that, thank you very much.
Thank you, Mark. As ever, very challenging, very interesting. Okay, I now hand over to Abby Parish, Associate Professor at Vanderbilt University School of Nursing, and Mar'yana Fisher, I hope I've pronounced that right, who's a PhD Fellow at the School of Nursing, University of Victoria. They're jointly presenting, and they have a PowerPoint that I'll now put up. When I remember how to press the buttons. Here we go, the embarrassing old man trying to put a, here we go. You should now be able to see that. Over to you.
Thank you for kind introductions. Can you see me? Because I'm not seeing myself, so I just want to make sure that my camera is on.
Yes.
Oh, thank you. I'll jump right in. When I was reading Dr. Djordjevic article, two things came up for me. And one was, is pain a problem at all? And if it is, do we require a solution for it? So from his argument, as I understood that, and in McCaffrey extending this, that pain is a problem. And but numerous examples from my own practice were telling me that it's not always the case. Sometimes patients embrace pain due to cultural or religious belief, or try to shield the family from their suffering, or assert control over their bodies, as in, the saying, mind over matter. If you don't mind, it doesn't matter. And sometimes pain is welcomed, as during exercising or childbirth. And I think in those instances, if we as a healthcare providers just want to drug that pain, that we are misunderstanding and missing some of the innate purposes aspects of human experience of pain. And the second thing that stood out to me, that perhaps we can switch our lens in discussing the phenomena of pain, because so far in the article, it was tethered to human bodies and nursing interventions that ought to focus on the same. Instead, I propose that their exploration of pain might perhaps benefit from a material semiotic lens. And so just briefly, material semiotics propose that the meaning, generally semiotics propose that the meaning of any word depends on the relations with this word has with other words. So material semiotics extend this focus to material world and examine how those network of different kinds of things, human and non-human, co-create each other. So when I was thinking about pain from Netherlands, interesting things starting to pop up for me. I was looking for in the phenomena of pain as a not as an outcome, but as a relational network of practices. So, for example, inside an abdomen, pain is a sensory response to tissue damage. But for the nurse attending to the patient with pain, perhaps it looks as a tightened jaw and a moaning. And for the patient's family, it looks like suffering. Then for doctor, it might look as a prescription of a hydromorphone. And for the pharmacist, the pharmacological aspect of preparing the hydromorphone concentration required. And for the Buddhist patient, for example, pain is the process of reaching higher state of consciousness. So in other words, pain is rooted in material practices and the relational interplay of numerous actors, and it varies across the context. Thank you, off to Abby.
Greetings, friends. To continue interrogating the assumption that pain is a problem to be solved, let's look now at the second half of that assumption, which consists of pain being something that nurses or even philosophers can or should solve. So I see this assumption being made more so by McCaffrey, and my ideas will be mostly agreeing with my colleagues on the panel who are advocating for embracing complexity in the science, experience, and treatment of pain. So the assumption that nurses can solve pain is easily debatable. Terminal pain, neurologic pain, functional abdominal pain, these are commonly occurring pain types that I see in my practice as a nurse practitioner in long-term care that can only rarely be solved, at least using 2024 science. The assumption that nurses should solve pain is also reasonably debatable. In cases like Mar'yana describes, in which pain is considered by the patient to be non-problematic, no intervention may be indicated. So we can consider assessing level of distress and or suffering alongside assessing for pain, as other panelists have suggested. Finally, the conceptualization, whether it's conscious or unconscious, of pain as a problem to be solved may also imply assumptions about the nature of pain itself, with this notion of solving conjuring an oversimplified, even linear or two-dimensional conceptualization of pain, wherein pain intensity increases and decreases along this pain scale. Yet we know pain has properties that go well beyond intensity: character, duration, frequency, occurrence over time, and the complexity of those properties may be neglected when we lapse into approaching pain with a really simple solve approach that mostly considers unidimensional intensity at a single point in time. Uncovering and challenging the assumption of pain as a problem to be solved could seem purely pedantic, but there seems to be a connection between the assumptions we make about pain and the ways that we conceptualize nursing, or the role of the nurse with respect to pain. So if we're thinking of the response to nurses to pain as simply being to reduce magnitude of pain along a linear pain scale, then we may also be making an assumption not only about pain, but about the nurse and their role or capacity, and in so doing, potentially diminishing the role of the nurse. So as nurses, we have the training to conceptualize complicated situations holistically, to engage with patients in complex interpersonal interactions over time, and to pursue avenues that optimize both short and long-term benefit to multiple parties. And this goes way beyond a simple solution orientation. If we accept an alternative conceptualization of pain as being something really complicated, and if we're open to options beyond solving for pain, this more expansive position opens us a wider array of options for nurses who are attending to pain over time. So for instance, we could distinguish between notions like solving pain, but also addressing pain or acknowledging or seeing pain. And this might be analogous to the times that somebody's talking to us about their bad day. They may not be looking for a solution so much as to be seen or heard, or even meaning making. And you can probably think of more options that you've used or that you've observed being used by your nursing colleagues for interacting with pain. Within this more complex array of options, it could be interesting to explore this notion that acknowledgement, or really seeing a person in pain and acknowledging their humanity and pain experience, might be a foundational or necessary step. So then, revision of this assumption that pain is a problem to be solved, and thinking of it instead as pain as an entity that nurses can interact with, this maintains the patient-centered focus that McCaffrey's definition of pain was chasing, while possibly being a better match with the complex nature of pain and the multifaceted role of the nurse.
Thank you. Really, really interesting again. Now, just 1 second while we have more button pressing. There we go. There we go. Okay. Well, thank you to everyone who presented. We'll now open up for questions in a second. If people have a question, if you'd like to pop that question into the chat section, or if you'd like to raise your hand, and then I'll unmute you so that you can speak. But whilst people are thinking of questions that they might have, I'll just abuse my position as oh, I don't know, what's this, ringmaster, and ask a question of all the presenters. Charles's paper appeared in Nursing Philosophy. Relatively few nurses read Nursing Philosophy, but it's an excellent paper. And what it does is opens up the complexity of the issue involved. For practitioners in clinic, a very large number of problems are generated once we move away from McCaffrey. And Barbara, I think, pointed to those, as did others. But the tension will remain between a patient claim and possibly the interpretation or who hears that claim. I don't think the tension is resolved in any way. So for educators who have to meet the needs of students for clear advice, and for practitioners who need to know what to do, what are the problems around embracing this sort of complexity of the sort outed by papers in nursing philosophy, papers like the one that Charles discussed? Now that's a very rambling question, so I should have thought of that more carefully, but would anyone like to respond to that? How are practitioners actually to make their way through this minefield once we move away from simple dictums such as that from Margot? Would anyone like to hazard a guess? Barbara, I thought it might be you. What's the way through? How do we unknot that?
Oh yeah, I just I think this is the type of complexity that I would love to see really embraced in nursing programs. I think we do too much time with these sort of more simplistic memes because they make us feel really good ourselves as nurses and about ourselves as professionals. And I think in my perfect world, we would bring an article like this into a nursing education program, and we would present probably the ideas, fairly simply through, just as Charles did today, really sort of unpacking it for students, but more importantly, give them case studies. Give them case studies where they really have to grapple with the types of complexities we've illustrated today. And I think, I don't know why we don't do more of that. At least we don't in my experience, but I think that's really necessary.
Okay, that's yes, okay. Lisa in the comments section says, what about patients who are unable to communicate their pain, neonates, people with dementia? How might the nurse acknowledge or address their pain? Now, I can't remember what Margot said about these particular patients, although I read quite a lot of her work. I'm probably just forgetting. Charles, what was Margot's position on patients who are unable to articulate their pain?
Sure. So she ends up in a very weird place, which is why this is a really important question. She basically says we have to default to behavioral scales. So what is it, like SNPs and NPAT and all these things. On the same note, she's very clearly disturbed and dissatisfied with this. So she keeps telling you over and over again, but if at all possible, get them to report their pain. Even if they are suffering from, say, dementia, get them to use language here. Which I think speaks to, again, there's a tension here, I think. And I think a better out might be, so if we take this idea that pain is complicated and that we need to go intersubjective, we're losing a key evidentiary source, but I don't think that's necessarily devastating. I think it may well be for her, though, right? I mean, so if we grant that pain is a really, really or pain reports are really, really good ways into pain, then you can lose it and it's going to hurt you, but it's not the end of the game. If it's the only access you have, you're kind of done. And that's where I took her to ultimately end up. That's why she's so keen on really wanting someone to use language, even if there are situations where they just can't any longer.
Okay, a couple of people have their hands up. I think Esther was first, then Fiona, and then Marie-Louise. Esther, would you like to unmute? What's your question?
It's not so much a question, it's more of a statement, if you like. I used to work in a thoracic recovery job, and I think the problem that we had at the time was that we didn't have anything else that we could refer to, so we had to go with what the patient said they were in. Having said that, at times I used to find that incredibly frustrating, because I would look at a patient and physiologically I would have said from their observations, etc., that they weren't in pain, and they certainly weren't overly distressed, but that's not to say that they were. So I had to treat them on what I could do, which was basically probably follow McCaffrey. So that doesn't necessarily mean say I agree with it.
Okay,
I find her frustrating in that sense, because I don't feel always that it hits the mark, if you like. But at that time, we would have used her because we didn't have any other way that we could manage it, and we couldn't ignore the patient saying they were in pain.
Okay, thank you, Esther. Fiona, Fiona Cameron.
Hello, can you hear me?
We can indeed.
Jolly good. So I'm a clinician, I'm a nurse, have been for many years, working in pain management in various guises, and this is all very interesting stuff here today. I've been teaching with caution the McCaffrey statement in the sessions that I've done for many, many years, and to some extent arguing against her statement. And the way I would teach it to people is that we need to recognize what she said. We don't really have a simple way of assessing pain. We can't get the painometer out of the cupboard and put it on someone's finger or on someone's arm to get a measure of what their level of pain may be. But at the same time, I think we have to hear and acknowledge what someone is saying. We, I think, need to honor the person's account of their pain experience, but I don't think we need to agree with it. And we need to bring our clinical common sense to the encounter that we're in and recognize the wider number of factors and limitations that we may have in addressing pain in the way that the patient may be hoping that we are able to do. We are increasingly aware, aren't we, of limitations of drugs and other complications of particularly opioids and gabapentinoids that have been quite freely used in the with the good intention of managing pain and solving pain, but they are not able to do that in the way that was once hoped. We have to be honest with ourselves about that. We have to be honest with our patients about that. And we have to be honest, I think, in our healthcare systems about that. And we're not always very good at doing that. I was at another webinar yesterday, and they were talking about pain in society and community. And one of the take-home statements for me, and I really love it, is they say, we must complexify, we must not simplify. We must complexify, we must not simplify. And that very much goes against this reductionist move that we have in healthcare at the moment, certainly here in the UK, and I think particularly in a UK nursing scenario where we want everybody being a sort of higher level generalist. We don't want people specialising anymore. And we seem to be keen to make things as simple and as straightforward as we possibly can. When actually, we have an increasing complexity of patients coming through our doors. So here in the UK, the Royal College of Anaesthetists says that about 20 to 30% of patients will be complex. From our own study here in my trust, it's about 50% of our list on the pain list for people being reviewed in hospital, and that's complexities of chronic pain, psychological factors, mental health conditions, personality disorder, addiction, etc., etc.
Okay.
Thank you.
No, thank you. Marie-Louise, I know you got some interesting comments coming in. Marie-Louise, however, you had your hand up for some time.
Can you hear me?
We can indeed.
Okay, I just wanted to add that back in 2008 here in the Netherlands, I was a nurse practitioner on a care 40-bedded cardiothoracic unit where most of the patients for most of the time obviously were sedated, but still, you know, obviously would have had pain due to their surgical intersection and obviously some of the medications, you know, that we were supplying for blood pressure management and sedation. And we put the visual analog scale and a psychological scale together, and also a scale of medications. And we tried that for over 8 months to see if that helped, you know, when we were looking at pain relief and obviously pain and suffering. And we did have some very interesting results, which meant in 2010, we did publicate, and we are, from what I can gather, still using that combined instrument. The only thing is it needs to be reduced, because obviously in clinical practice, nurses need, you know, to have something that's, you know, relatively quick to go through. At the moment, it's a 23-itemed scale, but I just wanted to add that yes, when you are in coma or, you know, unresponsive, there has been research done, you know, on intensive cares to try and see, you know, whether the patient is suffering and whether we can actually, not just looking at their visuals, you know, their grimace or, you know, their, you know, bodily functions and so forth. But maybe it's not, as I say, gone worldwide. But thank you.
Thank you. So we need to embrace complexity and at the same time have simple tools to use. No conflict there. Paul, you have a question.
I was just wondering. Oh, hello. Sorry, what's that? I think I've pressed the right buttons. I hope you can hear me.
You can.
This dictum, dogma, I think those terms are great, but we're treating them as a kind of ontological problem or an epistemological problem. But I think another way of looking at it is it's a kind of a premise in a normative argument. And if you kind of strip back, I mean, I think the stuff Fiona said earlier on was just spot on, actually. But so I'm not quite sure if this has to, but if you try and strip those kind of philosophical problems, which for all Barb's enthusiasm simply aren't going to be treated in detail in a pre-registration undergraduate course, if you strip those away and just concentrate it on it as a premise in a normative argument, does that kind of make a difference? Because, you know, nurses basically, as a premise, it is, look, the patient's in pain. What should I do about it? Well, you know, where do we go there? Sorry, that's a rambling question, but it's a kind of an invitation to come back to the practical action guiding sense of what this statement actually means.
Barbara or Mark, would you like to come in on what Paul has said? Barbara, I think you probably agree with Paul. Or Mark.
Oh, I agree with Paul. I think that's right. I think that this is a really important, in many ways, more important than treating this as some kind of semantics or ontology or epistemology. It's so much more complicated on those scores. But as a fundamental ethical orientation, yeah, the patient says they're in pain. This is something you have to deal with, and that doesn't tell you how. But there's but yeah. So I think that's actually right. It's that this is a clinical recommendation about how to orient yourself, not so much a philosophical intervention.
Yes. Okay. Yes, you're probably, yes. Okay. Now, just before we continue, I know some people have to leave after an hour, and so for those who need to go and actually do some work, depending upon where you're placed in the world, I'd just like to say, obviously, thank you to all of today's speakers: Charles, Barbara, Mark, Abby, Mar'yana, and indeed, thank you to everyone who took time out today to be here, and the recording will be made available to everyone in due course. And again, just a final plug for next week's online event. Olga Petroskaya's excellent book, Nursing Theory, Postmodernism, Post-Structuralism, Foucault. Don't be put off by the title. It's really an excellent book, and that'll run on May 23rd, kickoff time at 5:30 UK time. Right, for those who don't have to run away straight away and do some work, let me just move over to some of the comments which have come in. Oh, my machine's jumping all over the place. So I might now mispronounce your name. Maria Manzano said, how would you manage unconscious bias on the side of healthcare providers? I think that is a problem, obviously, once we take into account the necessity to judge and to reach a decision about the testimony we're given. And I think that is a problem for practitioners. Chuck says the discussion drives home the reality that pain, expression, assessment and treatment is complex, which is true, and yet at the same time we have to have simple rubrics and ways of working through this thing. Lisa, some conditions are very painful. Patients just become addicted. Sickle cell disease is a problem. Chuck, Margot began an important discussion of pain phenomenology that we continue. Charles adds, back in the clinical skills of nurse needs to perceive complex reality. And Nikki, interesting discussion. Would make a really useful debate in nurse education. And yet the problem perhaps is that actually it's difficult to introduce complexity into nurse education, given that practitioners actually need to know and to be told what to do. It has to be simplified in order to be practical. And again, I hope I don't mispronounce Marnie Hamilton. So much of pain is what the patient says it seems to ride on the interpretation of the word says. There is the assumption that language is the only meaningful communication between humans. Are there not other ways to communicate experience, such as behavior or what is left unsaid? Yes, and how fiendishly complicated is that? While there are complications in the interpretation, we have to remember that even language requires indeed interpretation. Yes, there's a lot in there. Charles, or Mark, Barbara, Abby, Mar'yana, have you any closing thoughts? Anything you would like to say, possibly about this tension between recognizing complexity and the need for clear rules of engagement when responding to people who, in one way or another, tell us they're in pain? And of course, Margot's definition of says incorporated both verbal and non-verbal communication. Charles, do you want to say anything?
Sure. So I guess there are two things I would say. One of them was actually mentioned before and came up a couple of times, which is I think that McCaffrey is trying to open a certain way of thinking about the patient, right? Take them seriously, right? They're not just making this up, etc. And I think that part of her, that ethical injunction is worth hanging on to. My worry here about sort of the way that this has been implemented, and this resonates with a lot of what the other panelists have said, is that you end up moving from that to simplifying to the point where things just aren't viable. You know, I think that there are reliable tools. I'm thinking here, so the US in 2011, our Veterans Administration came out with a new pain scale that integrates behaviors into pain assessment. Even something that small strikes me as a good step. And I think that if nothing else, reminding students especially that this is sort of a comic book version and there's a point to it, but you can't take it literally, is critical, lest we end up reinforcing these images of, you know, the job of the nurse is to give the drugs the doctor orders to the patient, and that's the end of the conversation, which I think is deeply flawed for any number of reasons. So that would be admittedly my not Completely cogent reply, I would say.
Cogent enough, thank you.
I'll jump on. I want to jump on the end of that because I agree, and I think that the tension between that you pointed out, Martin, between the simplicity of any kind of instrument of scale and then the real complexities. I think that's. I mean, I'm not a nurse educator, so I really can't speak to these issues very well. But these are tools. They're just tools, and one of the dangers is that they're taken to be somehow criterial or definitional, or all I need to do is apply the tool and then I'm done. And I think that if there's a gap in nurse education, it's teaching them that these are tools and that there's a whole lot of context. I get back to Barbara's case studies. The case study started out with, okay, I applied the tool, but right, now what do I do? That's not the end of the show. And so that has to be somehow in the education as well.
Yes. Barbara, do you want to add anything?
I'm just going to add a plug for complexity. Honestly, I think we need to move toward complexity in nursing education and not worry about telling nurses what to do. I'm just looking at Lisa's comment here in the chat. She's talking about define addiction and painful condition from the treatment of actual pain. That's the very type of complexity that we need to be helping nursing students work with, because that's the world they enter. Physicians have been doing that in their education forever. We need to quickly move toward a different model of education where we don't present what you should do. We do present, here are the factors you need to consider in a case.
As ever, I find myself agreeing with you totally, and yet earlier today I was drawing up slides for lectures in a few days' time where I reduce incredibly interesting things to 2 or 3 bullet points in order that everyone can leave the room with enough knowledge about what it is they've got to do. It seems a difficult tension. Abby, did you want to add anything in? Last thoughts?
Well, I am a nurse educator, so I'm really pumped at how much of this discussion has actually been about nursing education. And I'm 100% with Barb. I think we need a reconceptualization. If we think about how do I capture this level of complexity in a lecture, that's going to be tough. It's just really hard to do that in a lecture. But if we flip it and we ask what activities, what discussions can we engage in that capture this complexity, that's much more possible. It introduces a whole new set of problems or challenges in terms of assessment and evaluation, but I think we can tackle those, and we need to tackle those.
Thank you. And Mar'yana, I do hope I'm not making a dreadful mess of your name.
No, it's Mar'yana, and you've been
Mar'yana, sorry.
quite well with it. I just want to add that I think if we're hoping to find a one size fits all approach to pain management and thinking about it, we're not gonna get there, or at least not anytime soon. And as you know, in my clinical practice, so I'm a palliative nurse, a clinician, and working with a lot of cancer pain that's oftentimes at the end of life stages is not managed or treatable at all. And then a new faucet that I just been thinking about are those folks that coming with trauma of various sorts, and they have a very different physical and behavioral expression of pain, maybe than those who didn't experience trauma. And so factoring the trauma-informed approaches to pain adds another layer complexity, as you know, patients who are might be unresponsive or have neurological disorders. So you know, we really need all year we can sit and debate this, and I don't think we'll get closer to anywhere. But having those debates is certainly a step in the right direction.
Thank you. We've had some more interesting comments come in. I quite like Paul's comment about elephants in the room regards the ability of many students to perhaps recognize, acknowledge, engage with the complexity that quite clearly exists around this topic. I think that is a really interesting problem, which we could spend some more time perhaps on a later date or another day discussing. are all of our students able to make the connections that we would want them to make. But let me just again thank everyone for being here today, and I'd like to wrap up. I can see people have left now, work to do, etc. So just again, a final thank you very much to everyone who made the time to be here today. I hope you found it interesting. Thank you very much, and I shall stop recording.